All right, picture the scene. It's the final Viva. You've barely slept for a month. You spent the last 3 years mastering the pharmacology of propofol. You can float a Swan-Ganz catheter with your eyes closed, and you know the difficult airway algorithm better than your own phone number.
You think you're ready for anything.
Exactly. You walk into the room, chest out, confident.
Yeah.
And then the examiner, looking over the top of their glasses, doesn't ask you about dosing.
Yep.
They don't ask about physiology. They ask you to explain the legal difference between negligence and battery in the context of a pre-medicated patient.
And just like that, the confidence evaporates. The blood drains from your face.
Exactly. It's the nightmare scenario. We spend so much time on the clinical how-to that we can completely neglect the legal what-if.
Yeah.
So, welcome back to the Deep Dive. Today, we are parking the physiology and picking up the law books. We are simulating that high-stakes final prep for a postgraduate MD student, specifically targeting the Gujarat University syllabus, but let's be honest, this applies to anyone holding a syringe.
It applies to everyone, everywhere.
I am playing the role of the exhausted, slightly cynical resident.
And I'll be the senior faculty, the examiner, the gatekeeper.
I'm ready for it.
I am ready for the role. And frankly, this is the most dangerous gap in a resident's knowledge. If you miss an intubation, you call for help. If you mess up the legal paperwork, you might be explaining yourself in court 5 years later when your consultant is long gone.
That is a genuinely terrifying thought. So, to keep me and our listener out of jail and on the pass list, we've got a serious stack of sources today. We aren't just Googling this. What are we working with?
We are going to the heavyweights. We have the 10th edition of Miller's Anesthesia, which is, essentially the Bible.
The Bible. Right.
We have Morgan and Mikhail's clinical anesthesiology for the practical high-yield stuff. We've pulled Wiley's anesthesia for some of the finer nuances.
Okay.
And because we are specifically looking at the Indian context for the exams, we are cross-referencing everything with Chinmoy Roy and the DNB question bank papers from the last 2 decades.
That is a lot of paper. And the goal here is twofold, right? First, survival. I need to know how to answer those 10-mark theory questions without rambling.
Correct. You need structure. Examiners hate rambling. They just switch off.
And second, the Viva. I need to know where the traps are. Because I feel like this topic is just designed to trip people up.
It absolutely is. The examiners know that residents view consent and records as boring paperwork.
Guilty.
So they use it to test your professionalism. If you treat the paperwork as an afterthought in the exam, they will assume you treat it as an afterthought in the OT. And that is a fail.
Okay. Message received. Loud and clear. Let's start with Part A, Introduction and Exam Framing. I'm looking at the DNB questions topic-wise list you pulled, and this isn't subtle, is it?
Not at all. Look at the frequency. Informed consent and legal aspects appeared in December 2000, June 2010, 2012, 2015, 2017, June 2022.
It's basically on a loop. It's a guaranteed question.
It's a signal. They are telling you, we will ask this. And the reason is simple. Anesthesiology is unique. In surgery, if a patient is unhappy, it's often because the scar is ugly or the knee still hurts. In anesthesia, if we screw up, the patient is dead or brain damaged, the stakes they're binary.
So the paperwork is our shield, our only shield sometimes.
Morgan and Mikhail puts it bluntly. The medical record is your primary defense in a malpractice suit.
Right.
Think about it. A lawsuit rarely happens the week after surgery. It happens 2, 3, maybe 5 years later. Do you remember what the blood pressure was for that appendectomy you did 3 years ago on a Tuesday?
I don't remember what I had for lunch yesterday. I mean, come on.
Exactly. So if you're standing in the witness box and the plaintiff's lawyer asks, "Doctor, did you monitor the patient continuously?" And you say, "Yes, I always do." But your chart has a 45-minute gap where you didn't write anything down.
If it isn't written, it didn't happen. I've heard that a million times.
And in the eyes of the law, you were out getting coffee while the patient went hypoxic. It's that simple.
Okay, that anxiety is definitely setting in. Let's channel that into the prep. We're going to break this into 3 big chunks: consent, the law, and records. Let's start with Part B, consent.
Good.
Now, if I'm sitting in the exam hall and I get a theory question that just says, define consent, and I write, getting the patient to agree to surgery, I'm guessing I get 0 marks.
You might get a pity mark for showing up, but you won't pass. You need to elevate your language. You have to sound like a consultant, not an intern just trying to get a signature.
Okay, so give me the phrase. What's the money phrase?
Miller gives us the phrase that pays here. You don't want to say agreement. You say autonomous authorization.
Autonomous authorization. It sounds a bit philosophical. Bit heavy.
It is philosophical. It's the bedrock of bioethics. It means the patient isn't just nodding along. They're actively using their self-rule, their autonomy, to authorize you to touch them.
Okay, but to explain that in an answer, I need to back it up. I remember there are 4 pillars of ethics from the OHS Intensive Care Manual. I usually just memorize the list and hope for the best. Autonomy, beneficence, non-maleficence, and justice. But how do I actually use them in an answer about consent?
You have to show the tension between them. That's where the points are. The core conflict in consent is usually between autonomy and beneficence.
Right. Autonomy is, I decide what happens to me. Beneficence is, the doctor wants to do good.
Exactly. And the history of medicine is basically a shift from beneficence to autonomy. 50 years ago, the doctor said, I'm doing this for your own good, and that was it. That was paternalism.
Doctor knows best.
Right. Doctor knows best. Today, autonomy is king. Even if your beneficence screams, this surgery will save your life, if the patient's autonomy says no, you have to stop.
Unless they're, I don't know, crazy. Is that the word?
Sound mind is the legal term, yes. We'll get to capacity in a minute. But first, you need a legal hook. Examiners love a Latin quote or a famous case. It makes you look well-read.
I've got Schlowendorf's v. Society of New York Hospital in my notes here. 1914. Is that the one?
That is the gold standard. Justice Cardozo, you should memorize the sentence. Every human being of adult years and sound mind has a right to determine what shall be done with his own body.
Adult years and sound mind. That seems to be the 2 catchy qualifiers.
Those are the key phrases. And that brings us strictly to the Indian context for your Gujarat University exam. What defines adult years?
Okay, this is where I always get confused. Is it 18 or 21? Yeah. Because for marriage, it's different. For voting, it's 18.
Stick to Chinmoy, Roy, and the Indian Contract Act. For valid medical consent, the age is 18 years. If you write 21, you are outdated. If you write 16, like in the UK, you are legally wrong. In India, it is 18.
18. Locked in. Now, let's talk about the types of consent. Because I feel like in the hospital, we just have the form. But the books, Miller, Morgan, they classify it differently.
The form is the end product. The classification is about the interaction. You need to divide it into implied and express.
Implied is the nonverbal stuff, like the patient just goes along with it.
Yes, but be careful. OHS Intensive Care Manual defines implied consent as inferred from conduct. The classic example is the blood pressure cuff. You walk up to a patient, you hold up the cuff, and they stick their arm out.
Right.
They haven't signed anything, they haven't said, I consent, but their conduct implies they agree to this minor, non-invasive thing.
But I can't use that for a spinal. I can't just say, he bent his back, so he implied he wanted a needle in his spine.
Absolutely not. You lose your license. For anything invasive or anything with significant risk, which is basically all of anesthesia, you need express consent. And that splits into oral and written.
Is oral ever enough? I mean, Chinmoy Roy seems to suggest it is valid.
Legally, yes. An oral contract is valid, evidentially. It's a nightmare. It's your word against theirs. That's why Chinmoy Roy says for complex types of treatment, written consent is the most appropriate legal term.
So it's not that oral is illegal, it's that written is defensible.
Precisely. It's about what you can prove years later.
Okay, so here is the trap I see residents fall into all the time. We get the signature, we check the box, we think we are done, I have the consent.
And that is the examiner's trap. Is the paper the consent?
You're setting me up. No, it's not.
No, Miller is screaming from the bookshelf on this one. The form is evidence that the consent process took place. The consent itself is the dialogue. It's the conversation.
Right.
If you get the signature, but you never explain the risks, that signature is worthless. It's a piece of paper with ink on it. It is not informed consent.
This is the medical Miranda warning concept Miller talks about, right?
Yeah.
Where you just list off a bunch of bad things.
Right. You know how cops in movies rattle off rights? You have the right to remain silent. If you just rattle off a list of complications, stroke, heart attack, death, sign here, that is not informed consent. You haven't informed them. You've just terrified them.
Okay, so what are the actual components? If I'm writing the 10-mark answer for informed consent, what are the bullet points I absolutely cannot miss?
You need 4. And use a mnemonic if you have to, but get them down. Number 1, nature of the procedure. Are we doing general anesthesia, spinal, epidural, or MAC? You have to be specific.
Number 2.
Risks. But not all risks. You don't need to list meteor strike. You need material risks.
Material risks. That sounds like a legal term.
It is. It means risks that a reasonable person would want to know before deciding. Common things like nausea and rare but catastrophic things like nerve damage.
Okay.
And here's where it gets interesting. Materiality changes based on the patient. If you are anesthetizing a concert violinist, ulnar nerve damage is a highly material risk.
Right.
If you are anesthetizing an opera singer, vocal cord damage from the tube is the most material risk in the world.
That brings the patient back into the center of it. What's number 3?
Alternatives. This is the one everyone forgets. It comes from a case called Salgo v. Trustees back in 1957. You have a duty to tell the patient if there is another way.
So if I want to do a spinal, I have to tell them GA is an option even if I think it's a bad idea for them?
Yes. You can say, I recommend a spinal because XYZ, but you have to disclose that GA exists. You can't just make the choice for them in your head.
And number 4, the last one.
Opportunity to question. You have to ask, do you have any questions? And you have to actually wait for the answer, not just mumble it as you walk out the door.
Okay, practical question. In many hospitals, the surgeon's consent form says at the bottom, in tiny font, I also consent to anesthesia. Is that enough? Can I rely on that?
If you are lazy, yes. If you are safe, no. Morgan is explicit on this. It's called the separate consent rule. Anesthesia is a distinct service with distinct risks.
Right.
The surgeon isn't explaining the risk of a post-dural puncture headache. You are. So Morgan says, ideally, you have a separate anesthesia consent form.
And for the exam, I should argue for the separate form.
100%. It shows you understand that you are an independent consultant, not just the surgeon's technician.
I like that. Independent consultant. I'll try to remember that at 3 a.m. Now let's get into the messy stuff, the special situations. This is where the Viva gets interesting. Let's start with the classic, the emergency.
The John Doe trauma case, unidentified patient.
Right. Guy comes in, massive trauma, unconscious, needs surgery now, no family, no wallet. Obviously, we treat him, but legally, what allows us to do that?
You rely on the emergency exception. Miller frames this effectively. It's based on the idea of implied consent, that any reasonable person would consent to life-saving treatment if they could. Society wants doctors to save lives, not wait for a judge to wake up.
Okay, but let's twist the knife. What if he is awake, he's bleeding, he's going to die, but he looks you in the eye and says, do not touch me?
Now you are in the danger zone. Morgan has a very scary sentence about this. Rendering care to a competent patient who does not consent constitutes assault and battery.
Even if he dies, I just have to let him die.
Even if he dies, if he is competent, meaning he understands he is bleeding, he understands he will die, and he still refuses. His autonomy trumps your beneficence. You cannot force-feed life into a competent adult.
That is hard to do in practice. I mean, the instinct is to save.
That's why you have to document capacity. You have to prove he was lucid, because if he dies, the family will sue and say, he was in shock, he didn't know what he was saying, you should have saved him.
So it's a trap either way, damned if you do, damned if you don't.
It is, but the law says competent refusal equals no treatment.
All right, let's make it more complicated. Kids, pediatrics is a minefield. In India, under 18 is a minor. Parents sign. Simple, right?
Legally, yes.
Yeah.
Ethically, no. This is where Miller and Kaushki-Jathanath introduced the concept of assent.
Assent versus consent. Break it down for me.
Consent is the legal power. The parent holds that. Assent is the agreement of the child. Miller says that children who don't fall into the legal category of adult still have brains and feelings. If you have a 12-year-old, you explain the mask, you explain the IV, and you try to get them on board. That is assent.
And if the 12-year-old says no, but the parent says yes, what then?
Usually, for essential surgery, the parent's consent overrides the child's lack of assent. You might have to use gentle restraint. But as the child gets older, the lines blur. Have you heard of Gillick competence?
It rings a bell. It's a UK thing, isn't it? Does it apply here?
It is, but Kaushik-Jathanath cites it for Indian exams too, so it's fair game. It comes from a case about contraception for under 16s. Basically, if a child under 16 has sufficient maturity and intelligence to understand the nature and implications of the proposed treatment, they can be deemed competent.
So a smart 15-year-old could theoretically consent to a procedure?
Theoretically, yes. But in the Gujarat University exam context, be careful, you don't want to sound like a cowboy, the safe answer is legal consent from parents, but I will strive for Gillick competent assent from the adolescent.
What about the reverse? The 15-year-old refuses something elective.
If it's elective, like a nose job or pinning ears back, and the kid says no, you generally stop. You don't force elective surgery on a teenager. But if it's appendicitis, you listen to the parents.
Okay, let's go to the ultimate refusal scenario. Jehovah's Witnesses, they refuse blood products.
This is a favorite exam topic because it tests your ethics under pressure.
Adult Jehovah's Witness, needs surgery, hemoglobin is 4. Refuses blood.
If they are competent and the refusal is informed, you respect it, even if they die. Miller is absolutely clear on that.
What if they are pregnant? That must change things.
The two-patient problem. This gets tricky legally, but generally, courts have upheld the mother's right to refuse for her own body, even if the fetus is at risk. However, in an exam, you would say you involve the hospital ethics committee immediately. That's the safe answer.
Okay, but what if it's a child? Jehovah's Witness parents say, no blood for my 5-year-old.
Here, the law changes completely. You do not let a child become a martyr for their parents' religion. Kaushik Jathanath is very firm on this. The legal principle is the best interests of the child.
So I give the blood against the parents' wishes.
In a dire emergency where death is imminent, yes. 2 doctors certify the need, you give the blood, and you save the life. You can argue it in court later. If you have time, like a few hours or days, you apply to the high court for a specific issue order, but you never just watch a child die because the parents said no to blood.
That's a clear line in the sand. I like those. One more scenario before we switch to the legal torts. Premedication.
Yes.
I've definitely seen this happen. The patient is anxious. The nurse gives the midazolam. Then the resident runs in with the form. Oh, shoot, sign this. Is that valid?
The knee-jerk answer, and the one most students give, is no, they are sedated, they are incompetent.
It seems logical. Midazolam makes you loopy.
But Miller actually adds a fascinating nuance here. He argues, yes, it can be valid if the medication improves their capacity.
Improves it? How could it improve it?
Think about a patient in 1010, pain from a fractured femur, or someone having a full-blown panic attack. Are they thinking clearly?
No, not at all.
No. They are irrational with pain and fear. If you give a small dose of fentanyl or a touch of midazolam, and they calm down, stop hyperventilating, and can actually listen to you, Miller argues their capacity to consent is now better than it was before.
That is actually really smart, but risky to say in an exam.
Highly risky. If you say it, you better back it up. The safe answer is, ideally, always get consent before premedication. But if the examiner pushes you, is it ever possible? Then you pull out that Miller nuance about pain and anxiety-reducing capacity. It shows deep understanding.
I love that. It's the difference between a pass and a distinction. All right, moving to Part C, medico-legal importance. We mentioned battery and negligence. I need to be able to recite the difference at the Viva table.
This is critical. You must get this right. Let's start with battery. Battery is an intentional tort. It is the unauthorized touching of a person.
Give me a clinical example, the classic one.
You consent a patient for a right knee arthroscopy. You go into the OT, get confused, and operate on the left knee. That is battery. You did not have consent to touch the left knee.
Does it matter if I did a perfect job on the left knee? Maybe it even needed it more.
No, that is the point. Battery doesn't require injury. It just requires unauthorized contact. Another example. You force a mask on a patient who explicitly refused general anesthesia. That is battery.
Okay, now contrast that with negligence.
Negligence is a breach of duty. You had consent, you were allowed to touch the patient, but you performed below the standard of care.
Like intubating the esophagus and not realizing for 10 minutes.
Exactly. You had permission to intubate, but you did it badly. That is negligence. Now, why does this matter for your career, practically speaking?
Insurance. Has to be.
Bingo. Most malpractice insurance policies cover negligence. They often do not cover intentional torts like battery. If you are found guilty of battery, you might be paying out of your own pocket.
That is a very, very practical reason to get the consent form right.
Indeed. And remember, the consent form protects you against battery. It does not protect you against negligence.
Right. You can't get a patient to sign a form that says, I agree to let the doctor be incompetent.
Exactly. A patient cannot consent to negligence. If you violate the standard of care, the consent form won't save you.
Let's talk about common errors in this section. What is blanket consent? Sounds bad.
That's the lazy form. I agree to any and all procedures the doctor deems necessary. Courts hate this. It fails the informed standard because it's too broad. You need specific consent for specific procedures.
And timing. We talked about premedication.
Yes, but Wiley's has a great line about not getting signatures from a patient who is heavily sedated. Sans teeth or spectacles.
Sans teeth or spectacles. That paints a picture. If they can't read the form because you took their glasses, the consent is invalid.
Precisely. It's about communication, not just ink.
Let's shift gears to the second half of our mission. Part D, record keeping. This feels like the boring part, but you said it's where we pass or fail.
It's not boring. It's your life insurance. Morgan lists 3 reasons why records exist. First, patient care documenting the plan. Second, continuity handing over to the PCU or ICU. But third, and for us today, the most important, legal significance.
Incomplete, inaccurate, or illegible records unnecessarily complicate defending a physician. That's the quote, isn't it?
That's the quote. If you have a bad outcome, the experts will review your chart. If your chart is messy, sparse, or contradictory, they will assume your care was messy, sparse, and contradictory.
So what is the Morgan standard for content? What must be in there?
You need to break it down chronologically for the exam answer. First, pre-anesthetic, you need the plan, the airway assessment, Malampati, mouth opening, and ASA status. And of course, the note saying, risks explained, consent obtained.
Then, intraoperative, the grid.
This is the big one. Morgan highlights the automated gathering versus handwritten. You need vital signs trends, usually every 5 minutes. You need drug timing and doses. You need the technique used.
And post-anesthetic.
Recovery status and instructions. You can't just drop them in PCU and vanish.
Morgan mentioned something about cardiac arrests and records. This feels like a trap.
It is. It's a huge trap. Imagine a code blue. Chaos. Chest compressions, people shouting drug doses. Are you standing there neatly ticking a box on the anesthesia chart every 5 minutes?
No way. You're trying to save a life.
Exactly. Conventional handwritten anesthesia charts are ill-suited for cardiac arrests. If you try to force the code documentation onto the standard grid, it will look messy. Morgan suggests a separate text note or a specific code blue sheet.
And here's where the discrepancy trap comes in, right?
Yeah.
The different versions of the story.
Yes. This is how lawyers win cases. Your chart says you gave epinephrine at 10.05. The nurse's code blue sheet says 10.0. The defibrillator printout says 10.08.
And the lawyer says, ladies and gentlemen of the jury, nobody knew what they were doing. They can't even agree on the time.
Exactly. Discrepancies are evidence of incompetence. So, after a crisis, sit down with the team and synchronize the timelines. Make sure the records match.
That is solid, practical advice. Now, for the characteristics of a good record, I need a list for the theory paper.
The 5 pillars. Memorize these. Accuracy, completeness, legibility, timeliness, and objectivity.
Objectivity is interesting. What does that mean in this context?
It means stick to facts. Don't write, patient was annoying. Write, patient was agitated and non-compliant with positioning. Don't write, surgeon was slow. Write, surgery duration 4 hours. Let the facts speak.
And Miller adds a point about recording trends, not just numbers.
Yes. Don't just be a number generator. Record observations regarding the conduct of the anesthetic. Patient bucking, skin flushed, surgical manipulation causing bradycardia. This explains why the blood pressure dropped.
Oh, I see.
If you just have a low number with no explanation, it looks like negligence. If you write surgeon clamping IVC next to the low number, it looks like you were monitoring the situation.
Moving to Part E, legal aspects of record keeping. We talked about if it's not written, it didn't happen.
Right. In civil cases, the burden of proof is preponderance of evidence. The record is that evidence. But I want to teach you a Latin phrase that is gold for the exam. Res ipsa loquitur.
The thing speaks for itself. I remember that from somewhere.
Correct. Usually the patient has to prove you were negligent. But in res ipsa cases, the negligence is so obvious that the burden of proof shifts to you.
Like leaving a pair of forceps inside the patient.
Exactly. Or Morgan uses the example of car keys found in a chest x-ray. In these cases, the record is your only hope to prove that the injury happened despite your best care, not because of your negligence. But honestly, if you leave keys in a patient, no record will save you.
Fair enough. What about record retention? How long do we keep these things for?
It varies by state, but generally in India, and for exam purposes, 3 to 5 years for outpatient, and often much longer for inpatient or pediatric cases, sometimes until the child turns 21. OHS manual discusses this.
And ownership. Who owns the chart? The patient or the hospital?
This is a common Viva question. The hospital owns the physical property, the paper or the server, but the patient has a right to the information. You cannot withhold the records from the patient if they request them. That's a transparency requirement.
Part F, common medico-legal pitfalls. We touched on discrepancies. What about alterations? I made a mistake, wrote the wrong drug. Can I just scratch it out?
Never obliterate an entry. Morgan warns this looks like deceit. If you scribble over an entry so it can't be read, the jury assumes you wrote something incriminating and tried to hide it.
So what do I do? What's the right way?
Draw a single line through it so the original is still legible. Write error, date it, initial it, and write the correct entry next to it. This shows honesty.
And retrospective entries. I forgot to write the intubation note. It's 2 hours later. Am I in trouble?
Permissible, but must be clearly marked as such. Late entry, written at 14:0 regarding events at 10:0. If you write it at 14:0 and pretend it was written at 10:0, that is fraud. Electronic records track the timestamp, so you will get caught.
Speaking of electronic medical records, or EMRs, Miller talks about this. Is it all good news?
Mostly. Legibility is perfect. No more guessing the doctor's handwriting. Timestamping is automatic. Miller states a mature system must 1. Record all aspects, pre-post. 2. Automatically gather physiologic data. And 3. Allow provider observations.
But Morgan notes a limitation. Artifacts. What's that about?
Yes, this is a big one. If the surgical cautery interferes with the ECG and the record shows a systole for 10 seconds, the automated system records a systole.
Right.
If you don't go back and annotate artifact due to cautery, the legal record looks like the patient died and came back to life. You have to curate the automated data.
Part G, risk reduction. How do I stay safe? What's the bottom line?
Follow the Morgan checklist for safety. 1. Document the process of consent, not just the form. 2. Check your equipment. The ARC source mentions machine checks and vaporizers. 3. Use standardized checklists like the WHO checklist. Miller loves that.
And 4.
4. Communication. Morgan stresses maintaining continuous verbal contact during sedation. If you are doing a spinal and the patient goes quiet, that's your first monitor. Document that verbal contact.
We are entering the final stretch. Part H, exam integration. This is where we bring it all together for the student. Let's do some rapid-fire comparison tables. I'll give you the left column, you give me the right. Ready?
Let's do it.
Table 1. Implied versus informed consent.
Implied. Nature is routine or minor, like a BP cuff. Documentation is usually none. Informed. Nature is invasive or complex, like anesthesia. Documentation is mandatory, a written form plus a note.
Table 2. Battery versus negligence.
Battery. No consent. It's an intentional act. Your insurance might not cover it. Negligence. You had consent, but there was a breach of the standard of care. Unintentional harm. Insurance covers it.
Table 3. Assent versus consent.
Assent. This is agreement by a minor, someone under 18 with capacity. It's not legally binding, but it is ethically required. Consent. This is the legal authorization by an adult 18 plus or a guardian.
Now let's revisit those Viva traps.
Yeah.
Doctor, the patient is 15 years old, appendicitis. Parents want surgery, kid refuses. What do you do?
Your answer is, this is an emergency, appendicitis. Therefore, the best interest of the child applies. You have parental consent. You proceed, but you try to de-escalate and explain to the child to get cooperation. If it were elective, you would respect the refusal.
Next one. Examiner asks, can you take consent from a patient in labor?
The answer. Yes, Miller cites that pain during labor does not necessarily render a patient incompetent. If they are rational and can communicate, they can consent for an epidural. Do not say no just because they are in pain.
And finally, how do I structure that 10-mark theory answer? How do I make it look good on the page?
Draw a flowchart. Visuals get marks. Start box. Assessment of capacity. Arrow 2. Disclosure of info like risks and alternatives. Arrow 2. Comprehension, making sure the patient understands. Arrow 2. Voluntariness, so no coercion. Arrow 2. Decision, final box. Authorization. If you draw this diagram, the examiner sees you understand the process.
Professor, this has been an incredible deep dive. I feel like I have a suit of armor now. For the Viva, at least.
That is the goal. Remember, the exam is not just about knowledge, it is about safety. They want to know that you are a safe pair of hands.
Let's wrap up with a summary for the listener to play on the way to the exam hall. Give me the top points.
Here is your rapid-fire recap. 1. Consent is a process. It's a dialogue, not a signature.
Got it.
2. Age is 18. In India, in Gujarat, 18 is the legal age. That's from Chinmoy Roy.
Okay.
3. Separate form. Always argue for a separate anesthesia consent form. 4. Record is defense. If it's not written, it didn't happen.
Right.
5. Battery versus negligence. Know the difference. Battery equals no consent. Negligence equals bad care.
Crucial.
6. No erasures, single line crossout only. And 7, your final thought. As Miller says, there is no consent if the informed, capable patient cannot refuse. Otherwise, the process would end with the physician getting their own way.
Powerful words. To our listener preparing for the Gujarat University MD exams, good luck. You have done the work. You have the sources. Go crush it.
Read the Miller chapter on ethical aspects and the Morgan chapter on medical records. You've got this.
This has been the Deep Dive. We are AI-generated personas based on your source material, helping you master the material. See you next time.